Today, right now, we're going to shift our focus to another important topic, different surgical techniques used in bladder extrophy repair. Recently in North America, there's been a lot of discussion, particularly on social media, about the Kelly repair, which has generated some confusion and concern among both families and providers. To help address this and add clarity, we've assembled a panel to number one, clarify the various surgical approaches to bladder extrophy, and number two, review the scientific published data on surgical outcomes, and number three, answer your questions and concerns about this complex and very controversial topic. So I'm going to introduce Dr. Shukla. He'll be leading the discussion on this topic. And Dr. Shukla is a globally respected leader in pediatric urology, serves as the director of the bladder extrophy program, co-director at the Children's Hospital of Philadelphia. In 2009, driven by a vision of equity and global collaboration, Dr. Shukla founded a groundbreaking surgical partnership in India. What began as a workshop has now grown into a model of international cooperation, bringing hope, healing, and world-class care to families across South Asia and Africa. His work reflects his deep belief that every child, no matter where they are born, deserves access to expert, compassionate care. Joining him will be a panel of surgeons, Dr. Dana Weiss from Children's Hospital of Philadelphia, Dr. Evalynn Vasquez from Boston Children's Hospital, and our previous panel here. Thank you.
Great. Well, thank you, everyone. This has been a wonderful afternoon. I'm sure we're all getting a little bit of the post-lunch doldrums, so feel free to stand up and stretch if you need to. This is a topic that I know probably a lot of you have been hearing about. And I think it's I want to try my best to stay within time and keep time for questions. And you can even, stand up and ask questions or put them through the barcode. But this is a really kind of an open forum. But first, I'll just do a little bit of introductory slides. And we have some wonderful experts here who do the types of surgeries that we're going to be talking about. So we can really try to get a perspective and get some of your questions answered that I suspect is on a lot of people's mind. So you have bladder extrophy. We know it's rare, and there are different. Your child is born. Many of you have probably had prenatal diagnosis, but many of you have not. Even with the best technology that there is today in prenatal diagnosis, we know that just depending on the studies, about 40% are just not going to be seen. 40–50% is going to be a surprise. There you are, and you have a child with bladder extrophy. And quick research starts, and hopefully you get transferred to a center of excellence or a place where there's familiarity with bladder extrophy. And then there's going to be 3 main repairs that are going to be suggested to you. One is the complete primary repair of bladder extrophy, the CPRE we call it. One might be now, as of recently, is the Kelly repair. But about a year ago, you would not have really been offered the Kelly repair in the United States. It was more popular in England, Australia, South America, Chile, Brazil, but it wasn't very popular in the United States. And then the modern stage repair of extrophy. And just so, shorthand, MSRE was popularized at Johns Hopkins by Dr. Gerhardt. Many of you might have been touched by him. In your life, complete primary repair of extrophy, which was really brought to the fore in the United States by Dr. Mitchell. And it's one that's done by us at CHOP here at Boston Children's, Wisconsin, and many different institutions around the country. And the Kelly repair, Dr. Lopez is a proponent of that procedure, as well as you've heard at Nationwide Children's Hospital, Dr. Kukau and Dr. Jayanti. So what is the difference? Now, I don't want to get overly technical because as parents, you really want to get to the base, but I've learned over the years that you all are very deep in the research type of families. You don't just take the answers, you really dig deep, you do the research, and you're probably more conversant than many of us might expect when it comes to a child with extrophy. The CPRE, everything right?
Sorry.
Okay. So the CPRE, the goal is a single operation approach. So as you know, at the time of surgery, now mostly these are done at around 3 months of age at many of the institutions. I can't say all because extrophy is done at a lot of institutions. There's still variation in how it's done. But in general, at major institutions, where there's a high volume, it's usually done at around 3-4 months of age. This is based on a lot of research, a lot of data that we can get into during the questions answer if you wish. But the goal is to close the bladder, the abdominal wall, repair the epispadias, and to do a bit of a bladder neck reconstruction at that time, hoping that this will allow the bladder to cycle and to hopefully what we call cycling the bladder, filling, emptying, and allowing the bladder to grow. The modern stage repair, as we talked about, popularized at Johns Hopkins, is 3 planned surgeries. The first is now at around 3 months. It used to be at 72 hours, but now even that is put off at many institutions where the bladder and the abdominal wall is closed. And I should mention the CPRE and the stage repair both use osteotomies. As you know, the bone incisions in order to bring the pubic diastasis together, the pubic symphysis back to the midline. And the stage repair has that as the first. And then an epispadias repair is done somewhere around a year of age. And then a bladder neck reconstruction will be considered around age 4 to 5, depending on the bladder capacity. If the bladder capacity is too low, you may hear of an augmentation as being an option, bladder neck closure, an augmentation of bladder neck reconstruction, or bladder neck reconstruction to see if the child can continue to void per urethra. And then the Kelly. Kelly is often staged. I think mostly it's staged. PJ, you do it as a staged approach?
It start, can I? Says number 3.
Yeah, we can hear
Yep,
you.
yep.
Yeah.
So it started as a stage as well. And now Mark Leclerc and other people are proposing the single stage after the 3 or 4 months. And yeah, just a one thing.
So yeah, so some in Great Ormond Street, I think they still do it as a staged repair in England, but there are other proponents in France and South America, and now Cleveland, where it would be a single stage repair, where they call it the radical soft tissue mobilization, where there's a repair done of the bladder, the corpora. The penis reconstruction is a little different, where the corpora that you saw in that picture from Dr. Lee is actually lifted off of the bones, off the pubic bones, in order to hopefully gain a little more length on the penile reconstruction. And sometimes a piece of muscle from the pelvic floor is taken and wrapped around the bladder neck in order to give a certain amount of bladder neck reconstruction at that time. And these are in general, that's just a broad overview, and we'll get into more details as we go through some of the thoughts here. Now, what do we know about these procedures? I know these are a little bit busy. I just wanted to put it all on one slide so you can kind of compare. We've talked about the stages, the timing. These are all pretty similar at this point. The steps, I went through in detail the steps, so I won't go through those again, but as you know, the goal is kind of the same, and they all have a bladder repair, putting it inside, covering it under the fascia. They all have a penile reconstruction, and they all have a bladder neck reconstruction, right? These are the goals, and it's just a question of timing and approach that I think varies between all of these, but that's the goal of all 3 operations. So to keep it simple, you want to get the bladder inside, You want to repair the genitalia in boys and in girls. You want to do clitoroplasty, and you want to, create a normal introitus in females. And in boys, you want to do the epispadias repair, and you also want to do a bladder neck reconstruction to help them gain continence, because these are things that really need to be sort of reconstructed. It's all there, it's constructed, but we want to sort of recruit those parts and put them in a way that we hope will work well. Osteotomy, definitely done in CPRE, definitely done in the stage repair, and it's not always done in the Kelly repair. Some do it, some don't, and we can talk about that. The bladder neck repair, as I mentioned, it's done at the CPRE at the time, but it also can be done sometimes. Some of you in the room may have had a second bladder neck reconstruction, and it can be done, and I won't say often done, but it is done in select patients when it's felt that it really needs to be done, that, we're having a lot of incontinence, they're getting a little older, but the bladder capacity is good. Maybe we can, go in and do a bladder neck reconstruction. Bladder neck repair is being done during the Kelly as well, and sometimes being offered, as many of you know, later on, that if you're having incontinence, perhaps that's an option. Now, what are the results? So for continence, and I'm gonna have everyone on the stage will kind of address this a little bit, but just high level. If you're talking about voiding per urethra, we're talking about children who have not been augmented. If you had an augment, bladder neck closure, Mitrofanoff, hopefully the continence rates are pretty good at that point. Yes, you are utilizing a catheter, but we are hoping that your continence rates are more acceptable. So that's not on this chart. So we're only including those children who are still voiding per urethra, that have not had an augment, and they may be on CIC, but if you look at not with CIC, just sort of high level, what can I expect? What can I tell a parent if I'm meeting them shortly after birth? We have that first 3 months while we're discussing what the results are gonna be. Then what we might say based on results on CPRE is that 40% of these children will be at least an hour to an hour and a half dry by 5 years. 40%. Doesn't mean they're fully continent. They might have some leakage with a lot of aggressive activity or sports, but we're hoping that that's the number, not hoping, that's what the data is showing us at this point. With the stage repair, about 25% are voiding per urethra, and I don't have the exact years, but it's around the same amount of time. It's about after that 5-year period where they get a decision whether they're going to go towards an augment or bladder neck closure, or they'll continue to void per urethra, about 25%. The Kelly repair, what you should know is that currently the data is much less. There is nothing really published at this point for long-term data, or those 5-year data for the Kelly repair. Doctors will give you their experience, but that experience hasn't gone through peer review and been published as of yet. However, the Great Ormond Street, where this has been popularized, the Kelly repair that has been taught to a lot of the world from there, they are presenting their data this year. For the first time, perhaps, long-term data on the Kelly repair in Vienna at the European Society of Pediatric Urology. It will be shown, and this is from the abstract, and I spoke to the author, and they're showing about 50% are dry day and night after 10 years, and 25% did get a bladder augmentation out of that group. So 1 in 4 got a bladder augment. Of the 75% of that cohort that are still voiding, after 10 years, about 50% have about dry intervals. So I think, the CPRA is 40% after 5 years. Kelly repair is saying 50% after 10 years. And the stage repair is, this is what has the largest experience published, puts it at about this. Publications, there's lots in CPRE. From Seattle, from Boston, from Philadelphia, Wisconsin, the MIBEC, the coalition between Philadelphia the institutional collaboration between Philadelphia, Boston, and Wisconsin. A lot of recent data on the CPRE, much data from the modern stage repair. As you all know, a large number of papers, perhaps one of the most numbers, is from Johns Hopkins and Dr. Gerhardt. And the Kelly repair, we're now starting to see the reports. But to date, those reports are lacking. There really is not much data that is published, whether in books or in literature, regarding longer-term outcomes with continence, penile length, and all of these questions that you might have with the Kelly repair. So that takes us to some of the questions, and let's get our distinguished panel involved. Let's start with Dr. Lopez. I'm just gonna start right to the left. So you have a baby born with exstrophy. They call you, Dr. Lopez, I have a baby with exstrophy. We're about 5 days, we just got home, baby's doing great. As you know, exstrophy babies thrive. There's no reason they shouldn't thrive after birth, unless of course if they have a premature birth or anything else. But if everything else is uncomplicated, you have some time to think about this, to do the research. Nobody should be forcing you or making you feel pressured that we have to go do surgery urgently. It's not a surgical emergency. We see children in India who walk in, right? 15 years old, 20 years old, not anymore, now that we've been doing this for 20 years in India, but it was not uncommon for a 10-year-old. It looks great, except sadly, you know, they have an unclosed exstrophy. So it is not a surgical emergency. So they call you, Dr. Lopez, and how do you counsel them? So just a brief outline, since we don't want to go to the entire, that's a 40-minute consultation or 1-hour consultation. But in a minute, what are the broad outlines of how you recommend the repair?
Yes? No? Yes.
Yeah.
So I will start probably with something from your data before, just a part of things. It's important to know that all the techniques that Aseem showed has some timeline issues too. One technique start before, then it was modified, and then came the last one, who's the Kelly. So the timeline impact in the long-term follow-up, impact in publication. To have data and publication in long-term, we wait at least 5 to 10 years of our technique to be around. So just to have that in mind. Coming back to your question, rather than start explaining what's the bladder exstrophy, what we need to achieve, what you have, I will focus probably in that family. It's understanding what's the long term of this baby. And probably they will look around Google, and I said, don't go to Google, just try to go to website that has the proper information, because in Google you will find at the beginning all the disasters, and your baby will be probably in page 20, and you'll never go to page 20. So I just suggest a couple of websites that I know that have proper information. And then we can discuss what about surgery or everything about that. But for me, the most important thing is that the family realize that they need to find a team that will stay with them the longest as possible. And a team that at the end of the day, they got say, here I am okay. Because technically, I can find 5 surgeons around the world on the state that can do the same surgery, another surgery, the same level of me, better than me.
So PJ, if I could just interrupt 1 second. So I know, I'm gonna do this. I have the moderator's prerogative.
Good.
So the question just came in. So how long has the Kelly been performed? And why would you consider, or do I call you a proponent of the Kelly?
A believer,
repair? Just to get to the
believer.
Kelly. Yeah.
So Justin Kelly proposed this around the 2000, so has been 25 years out there. And I do or perform or propose this surgery because I think that we don't do it osteotomies as in the major of the patient. It's a very good possibility. You don't crush the bones, because the possibility or the aim to crush the bones is to get the diastasis together. And now we know that at the end of the day, they will come apart anyway as well. Second, because it's the surgery that try to apply the maximum anatomical dissection and reconstruction as possible. We know that it's a bladder that has been formed in a way that is very difficult to get in the normal way, that everything is falling apart and we need to put it together. And this, at least for me, anatomically try to do at best. Last but not least, especially for boys, allows the boys to get lengthened on the penis, because as Ted showed this morning, the penis is in this position attached to the bones, and the Kelly, what it does, remove that attachment and get it straight in the middle. And that will allow to just gain a little extra centimeters at the end. So that's why probably I propose this one rather than the other two. Having said that, I will come to the other part. If my team, it's not, and I would say another thing that just before I forget, Ted also here in Boston does the Kelly in some patients. So there's more people, and it's not just Columbus or ourselves. But having said that, I think that the most important message at that stage when the baby's just born, find the right team, that your gut thinks, here I feel confident, rather than a technical issue.
Thank you, PJ. So, Dr. Weiss, why do you prefer the CPRE? And since that was addressed, why don't you just talk about an osteotomy and what that entails today in terms of immobilization or those types of things. So why do you like the CPRE? And talk a little bit about osteotomy.
Sure. So, I mean, I think to be totally honest, and someone said earlier today, you do what you're comfortable doing, what you know how to do. And that's how I was, trained to do the CPRE. Sorry. My deep voice doesn't project. And so, it just, and it's I think the why is that's how I was trained to do it. However, in seeing other ways, seeing stage repairs, I haven't witnessed the Kellys, but I've seen videos. I think I'm still like the CPRE for several reasons. One, talking about what Dr. Lopez was saying, reconstructing the anatomy as it, I hate the word normal. What's normal? Maybe an extra V, that is normal. But, as typical as possible. I think the CPRI does that because for the osteotomy, the bones are wide apart. By bringing the bones together, you're not just bringing a number of the diastasis together, you're bringing all the pelvic floor musculature together to help it all work in unison later on. As you all know, we work so closely with Sarah Cooper from physical therapy to get all those muscles working together. And yes, while you do an osteotomy, the numbers all spread apart. A paper will be published within the end of the year, I promise. It's all written, showing that, even though the numbers spread apart, they don't go back to fully as wide as they were because the child grows. So you might rotate the pelvis in, reconstruct the normal configuration. Yes, it spreads apart, but the angle formation that you've changed stays the same. So I think you do gain something from the osteotomy. Plus, Dr. Gerhardt's group in Hopkins has shown in multiple publications that osteotomies do help that initial bladder closure and that there is a higher failure rate, dehiscence rate without osteotomies. And I've read papers from other centers, not some of these big ones that we've mentioned, indicating that even with a Kelly, they've either had to do osteotomies because of a series of dehiscences. So Dr. Alan Wien from Penn once said, when you want to know the data of something that you really care about, read a paper that's not about that topic, because it'll be in the fine details of something that's a different topic. They'll just mention it because they're not trying to demonstrate something. And so that's a very, very telling statement. And so I think there are, reports at least of dehiscences or need for osteotomies in the end. Then going back to the CPRE, I think versus the staged approach, you are bringing everything together in continuity and allowing for that early bladder cycling. Also, by the gentle tapering, it's not a quote unquote formal bladder neck reconstruction. We're not creating like a tight stricture. If you get it just right, when you go back and scope these children after a CPRE, the bladder has grown, the bladder neck can coapt. We just saw a recent picture of a scope, and I've scoped children myself, and you can see the bladder neck that is not scarred and fixed and actually is closing when the flow is off and opening later on, demonstrating that that's reconfiguring the most normal anatomy possible, and which gives that child, I think, the optimal time from 3 or 4 months, 5 months, whenever you close them, on through childhood to grow. Now, it's not the slam dunk, you're dry at age 4 or age 5. And going back to sort of how you counsel families, when I meet a family, and I've met, at least 4 of you out there before, I don't tell you you're gonna be dry by 3 or 4 or 5. It's a long road. However, the goal is that if we can get you there by age 10, 12, or 15, then you're set for a lifetime, rather than that, trying to hit the perfect milestone by 4 or 5.
Thanks, Dr. Weiss. So Dr. Vasquez, who led the extra-fee program at UCLA, USC.
Yeah,
You had-
CHLA.
CHLA, Children's of LA, Children's Hospital of LA, and now is back here at Boston Children's, where she trained. Dr. Vasquez, are you still a proponent of the CPRE after your experience in Los Angeles? And could you expand a little bit more on what Dr. Weiss began with, which is this question that often comes up at around age 4, age 3 to age 4. My child is wet.
Mm-hmm.
Should I do something? Should we be intervening? Is this a problem? Am I not doing right by my child by not intervening sooner for some type of reoperation or reintervention? Let's say age 3, age 5, age 7. So what are your thoughts on that and which procedure? But we don't have to get in detail of how you do it, since we
Sure.
know we talked about that.
Sure. So I am a proponent of the CPRE, and I am biased because I did train at Boston. And so and we are, part of the MyBet group. So we did commit to the CPRE. So I am a proponent of that. Just like Dr. Boer, I am also a lifelong learner. And so I'm also willing to learn advantages of the Kelly procedure. I think one of the advantages of the CPRE is that there isn't that immediate surgical procedure that's done right after birth with the modern stage repair. So you do have that ability to bond with the baby. They're not, taken, straight from your arms and straight to the OR any longer. You're able to bond with them. They're able to grow. And so the anatomy changes in those first 3 months of life. Their blood supply changes, their blood reserves changes. So there's a lot less risk for delaying the repair until they're at least 3 months of age. The anesthesia risk also changes and their physiology changes. So I am a proponent of waiting until they're at least 3 months of life. As far as continence goes, this is such an individualized conversation. One thing that I think that we really need to be aware of and advocate for is their renal health, and that continence may be a protector of kidney health. And so pushing for your child to be continent and dry and out of diapers may be a little short-sighted. And so making sure that your team is also evaluating their kidney health and making decisions based on what that individual and family is ready for. I have some patients that I've talked to year after year after year, asking them when they're ready. Continence surgery is a big surgery, as every surgery is. And so meeting that child and meeting that patient where they're at and asking what their desires are. Some of them are ready at 4 years old to be completely dry, and whether that means catheterizing, whether that means urinating every 2 to 3 hours, whatever that means, making sure that that child has a voice in the decision for their care. And that is going to range, and that becomes very individualized. Because this is such a rare diagnosis, I think we're learning more as medical care providers and surgeons from our patients, asking the right questions and having the right conversations. And so I think it's a great conversation to start having, but because every patient is going to have different desires at different ages. I have some patients that are completely fine being in diapers, through high school. Because they just want to continue their life, and they're, quite scared of having surgery. I have some patients that don't have the support, from their family and from their resources to be able to irrigate and have catheters, or have the mobility and have, all of the support that is required in order for them to catheterize and to be continent. And so it's hard to standardize and, create like a protocol, but I think taking every patient and every decision as a whole with the family and with the patient and what their desires is important from the get-go.
The Spanish team. So, we spoke about Great Ormond Street and France. There is pockets of popularity of the Kelly. It's not even in the entire nation, but at Great Ormond Street, at Dr. Leclerc in France. What is your approach in Barcelona to a newborn with extrophy?
Spain don't have experience in Kelly repair. Most of the teams are doing a modern stage repair, but Barcelona started to do mitral CPRE in 2001. So I'm learning CPRE. So I'm more confident of CPRE because it's impossible to standardize a procedure and it's very rare. They are a few cases per year, not a lot of cases. So you feel confident, you have good results. So I am an open-minded person. I think is the Achilles repair they will have much better results than the CPRE, for example. Okay, I will have to learn and to change. It's not very different from CPRE, the Achilles repair. But now I think it's not time to change.
Sure.
Now.
Yeah. I think that is true, that a lot of us who do this operation, it's complex enough. If you get a familiarity with a way of doing it, you're hesitant to change that because it is something that it takes 10 years to know if you did something good. So if you're going to change, you want to really know if this is going to have a positive impact. So PJ, how much time do I have, by the way, Ted?
We have time.
We have some time. Okay, just cut me off. So I haven't watched the itinerary. So PJ, one question we get a lot is with the arrival of the Kelly onto this side of the Atlantic, or this north part of the Atlantic. Sorry, it has been on this side of the Atlantic. Be careful with that. Pacific, but yeah, you're on the other side. So on this side has been this question of the child who had a repair, whether a CPRE or a modern stage repair elsewhere, or not elsewhere, at our institutions, and is having incontinence at around age 3, age 4. And there is a belief that an intervention could be helpful in perhaps improving things, improving continence. I'm not sure about whether also improving cosmesis. Is that an approach you take on in Cleveland? And if so, what do you think the advantage is?
So let me start from the back. I think that to promise continence in a redo case, it's really naive, I would say, because it's not the natural tissue, it's a scar tissue, probably 1 or 2 surgeries before. So it's not the best scenario to just have a surgery and say, don't worry, we'll do this. And then we will get out without any issues, 100% sure that we will get continence. I will run away from that because it's very difficult in any redo surgery of continence to get continence. It's achievable, but it's not 100%. So, and probably what I will offer is what I have been learned, what I'm confident with, and what I used to do, and what I feel good doing, it's the Kelly. If I were born here and probably trained by you, I will be in the CRP, and then I will be a believer from the CRP. So following your thought, and I agree with that. But in the Kelly, my belief, and that's why we were discussing this panel before about believers, my belief is that because we're trying to get the anatomy and try to approach the tissues in a way that could be as continent as possible, the rate of continence in a redo could be a little higher. But then you need to get involved another full of elements that are out of the discussion. One, it's not just the surgery, it's the surgeon. It's not just the surgery and the surgeon, it's the in total environment. So we can do the best beautiful surgery coming out from the OR table, and I have lived that on my own, moving to the bed that will take that child to the PICU or to the room, and then one of the catheter gets stuck in one of the bed, boom, catheter out, all our rate of success drop dramatically. So it's not just the surgical team, it's the whole environment that will give you the most beautiful and successful approach. As I would like to discuss, and probably we can discuss it later, for me, surgery, it's just one point of the whole journey that you are living. Probably it's the most stressful one, yes, but it's not the most important one. Because if you are not feeling comfortable with the whole environment and you don't have what I am passionate about is the user experience, the whole team from the front door until the end of the journey, commitment to this, the surgery could be the best surgery in the world, but your experience is really bad. You can have the worst complication, but the whole journey has been beautifully, the complication could be copable. So answer to you, probably I will propose that, being aware that trying to get the expectations in the right level.
Perfect. So I think we could go on, but are there questions in the audience? Should we do it only through here, or I could just walk around with the mic?
I'll ask some questions on this. Some surgeons who do the Kelly repair have set their rates of dryness without atrophin off as high as 80%. This appears high.
Right. I think whenever we hear that, it would be good to see the data published that has undergone the rigors of peer review. Whenever I quote my success rates that I'm doing well, of course, I have a little bit of my own bias that's in there, my surgeon bias. I want things to have gone well. Have we really looked at that rigorously? Have we looked at the amount of wet pull-ups or underwear, or measured that? How are we calling it continence? Is 1 hour okay for continence, or should it be 3 hours? What do we consider continence? Many of these things go into that, as Dr. Lopez beautifully showed. His large study showed there's so much variability. Do you consider continence? Well, you're catheterizing, but you're dry. Does that go into the same continence as somebody who's voiding per urethra but has to void every hour, versus somebody who can hold it for 2 hours but has to use a catheter to empty? So this can vary, and that's why it's so important to see that go through the peer review process. So we try to standardize the terminology of what continence means to you versus to me or Dr. Lopez or everyone down the line.
And just one comment there, and this is something that, again, anyone I've talked to always knows I say, is what's the denominator? Because I think 80%, if you're only looking at those kids who are voiding without a catheter, it could be, let's say, 8 out of 10, because I'm not going to be good at the math. But if you've operated on 25 kids, and it's 8 who are, I shouldn't have done that. Oh no. If it's 8 out of the 25, then it's only going to be around 30%, which is a more reasonable
And
number.
if the other 17 have had an augment or bladder neck reconstruction, then you're only looking at the 8 that you haven't done, and you're saying 80% of them are dry. That really helps your number. So I think that's what goes into that. Another one there, Ted?
There's many questions, but I think just reading the questions, the audience may be confused. The Kelly and a redo operation to do some type of Kelly are different things, right? I think there's a little bit of confusion mixing and matching, and Dr. Lopez touched upon this, but
let me just take it out of the question. I know where we're going in that question. I know where we're coming from that question. As you probably are aware, we haven't offered our program yet because we're building our program in a slow, easy way until we are ready. And for our program to be ready means that we are bringing also 2 experts, Marc Leclerc from France and Imran Mushtaq from UK, to help us, because we are truly believer that the people who has more experience and has more hours of fly can help us more in starting a program. So, and I know that Columbus raised the program last year or this year, and they are saying that this is the surgery for this condition. I don't believe that is the surgery. You have other surgeries, you have other centers. You need to go where you think that you are in the best hands for your child. If you think that this surgery can give you some good expectation and hope in getting that continence or other things, great. But if not, if you're not doing that, you are not missing anything. That's what I mean. If you are in this hospital or you are in Philadelphia with a good team, with a good surgeon, in another kind of technique, and you're happy, stay there. You're happy. Don't move to another place because someone said that we are the best, because I don't think that nobody can claim that. That answer your question, Ted?
So, yeah, thank you, PJ. If I could, Dana and Evalynn and Barcelona group here at the end, Dr. Bujon, what would you do for a child who is age 5? Okay, had a nice repair cosmetically, you know, of course, we all want everything to be better, but all things considered, is stable. The child is leaking, not really many dry intervals, thinks that maybe wakes up and pees with a decent stream in the morning, but then during the day is wearing pull-ups, is sort of dribbling a bit throughout with activity. Maybe at sitting, can hold it for a half hour, 45 minutes, but then is kind of dribbling. Ultrasound looks good, kidneys are healthy, have not had many UTIs, child is quite happy, but you know, as any parent would have, there's some anxiety. Are we headed towards getting better? So what do you think in terms of waiting at age 3 and saying, you know what, you might be better off by age 7 with no surgery, so give this some time, versus, you know, maybe an intervention would help. And then in that case, what would you offer with the CPRE?
I think one of the things that I would say is if you have that 3, 4, 5-year-old, there are some interventions they can do which are more investigations rather than interventions to see whether there's like things are on the right path. And there we will start with a video urodynamic study, which can tell you a lot. It tells you the shape of the bladder, the capacity of the bladder, and a functional capacity. One thing you can do, you start with doing an exam under anesthesia, looking in with the cystoscope, making sure that the tissues look healthy. You can occlude the bladder neck and see the capacity. To me, that's actually not really the real capacity because a bladder usually can stretch anyway. So that gives you some information. But really taking the child and either with a suprapubic tube or urethral catheter, doing a video urodynamic study can tell you, what does the bladder look like? What are the pressures in the bladder? Is there overactivity? Does the bladder neck look nice and closed and supported, and yet the child's leaking? Or does it look fixed and wide open and it just gushing out? In the fixed open gushing out, even I have done redo bladder neck procedures because I say, hey, that child's not going to have the best chance. However, if the bladder neck looks closed, if the pressures go up or if there's overactivity, we can start medications. If the bladder is beautiful, maybe the bladder doesn't squeeze, then you might say, hey, you know, we might need to assist emptying. But otherwise, if the bladder looks good, it has a good contraction, say, hey, this is when you're going to double down on your efforts of bladder training, pelvic floor physical therapy in patients. And then we're going to see how you do over time.
I fully agree. I am not an advocate of rushing to the OR to achieve dryness, especially if that's not really the bother. Again, I think the health of the child is the biggest priority. So, you know, a lot of times these kids are going to have reflux. And so sometimes tightening the bladder neck too much can overcompensate and cause that reflux to worsen. And so now if you're not reimplanting and if you're not addressing the reflux, are you putting them at risk for going into urinary retention? And then if you're not fixing the reflux, also, you know, giving them increased risk of pyelonephritis.
Okay, so
Yeah,
sorry,
go ahead,
no,
go
no.
ahead. Yeah, I
said-
actually was going to ask you a last question.
No,
since,
as I said before, we are more conservative now than a few years ago. No, so We start with the physiotherapy and mid-overgrown also. And sometimes it depends of the pressure of the social pressure of the parents. No, we try to wait until not the puberty if you can. But sometimes it's difficult with the parents' pressure to the school or the use of nappies. And sometimes, if, for example, you do a cystoscope and you see the bladder open, okay, so and the perimontanum is inside or south of the bladder is another predictor of the continence or not. And sometimes we inject the Bilken agents. We know it's not used here in the United States and not a lot, but in Europe, yes. So we know it's not the definitive treatment, but sometimes they increase the resistance and then to try to avoid to do a bladder augmentation in the future. So it's
Can I just?
Yeah. So how's our time, Ted?
It might be last.
Shortly.
Okay.
The only thing that I want to stretch here is that don't get the impression that we are avoiding and delaying the continence. So it's, as Dana said, it's a study. It's a bladder that doesn't work as used to work. But if some patients, some parents would like to get it because they cannot go to school with nappies, because something like that, the thing that we can do. So my belief, and this is something that I share with parents, I don't see that a patient with a bladder extrophy should wait continence if everybody in the room is ready to go for that. Go for that means a lot of work, a lot of effort, a lot of surgeries, but doesn't mean that we can do it.
Yeah, I think you heard a philosophical bias here on the dais, which is that we didn't talk today about augmentation. When should you augment? When should you do a bladder neck reconstruct or closure with a Mitrofanov? And because these are very individualized, right? And I think philosophically, the number of these have gone down a lot. At least the people here, we don't have the MSRE to speak for that side, unfortunately, on the table today. But in general, we are waiting because there is some data that is showing, as you saw, at 5 years, you start seeing these improvements. At 10 years, you see these improvements. So if you've already done the augment or the bladder neck closure, you didn't get to 5 years, you didn't get to 10 years. So it's when we have the right patient that we think we can wait, and we're trying to bump that number up so that we can see if we, now that you might be sitting here with a child with an augment and say, my child is great, totally dry, 3-4 hours, no diapers, like what's the problem here? And I think that's a very important point, and that's not on this table. We could debate, that'd be another whole a conversation. But so if we didn't cover that, we will in the future just bring that up, and we can. But right now you hear that the children born today, the procedure has changed so much since I started doing extra-fee surgery. When PJ started doing extra-fee surgery, what we do has changed completely. So it's very hard to compare if I saw a patient 20 years ago and where we might be versus a child who's 5 years old and the procedure they've had and where we are. So with that caveat, I will end this panel. Hope it was useful, and catch us in the halls if you have any questions and things you want to talk about. Thanks.